Good morning, everyone, and good morning to EPs, Dr. Fairuz, Dr. Vila, and all seniors and colleagues. Today I'll be presenting about ENT emergency. So ENT conditions can be immediately life-threatening by causing ABC problem, which is airway obstruction, airway compromise, breathing difficulty, and circulatory compromise. Common ENT emergency that we can see in green zone or yellow zone is foreign body, trauma, or complications of ENT infections. So I'll start with ear. For foreign body in the ear, it is a frequent emergency encountered in children with objects such as small toy parts, stones, beads, pencil leads, insects. So in adult, a vagrant insect may be trapped in the ear. Symptoms can include discomfort, decrease or loss of hearing, pain, sense of fullness, agitation, bleeding, and buzzing in the ears. So complication can perforate the tympanic membrane, infections, and erosions for the late complication. So management definitive is of course removal of foreign body. So if the button battery, if the foreign body is the button battery, it needs to be removed immediately to prevent burns or erosions of the mucosa. So if the insect is alive, we need to use mineral oil or 1% lignocaine or olive oil, or usually in ED setting we use sodium bicarb to insect first and then to remove with forceps or suction. This is to prevent further irritation while removing the insects. And for organic materials such as tissue paper, food materials, sponge, we need to avoid using syringe as it will wear up and causing removal difficulty. So in intact tympanic membrane, we can attempt to use irrigation method So usually some of the instruments is suction, alligator forceps, right angles, hooks, or wax curette. But if we are not confident or the attempt to remove the foreign body seems difficult, we need to refer ENT for removal. Okay, for ear trauma, covered auricular hematoma is usually resulted from blunt force trauma, usually from spots. Auricular hematoma is the blood accumulates in the subperichondrial space and can result in decreased blood flow, cartilaginous necrosis, and infection. The complication is usually cosmetic, cauliflower ear due to delay in evacuation of hematoma and treatment. So we can do IND or needle aspiration kalau patient came in with auricular hematoma, and then do the compression dressing such as bolster dressing to avoid reccumulation and cover with antibiotic. So for ear infection, otitis externa is the inflammation of the external auditory canal. Signs and symptoms include itching, pain, tenderness, erythema, canal edema, and discharge. So management is usually gentle irrigation and suction. We need to ensure if the tympanic membrane is still intact before the gentle irrigation. So can cover with antibiotic or steroid drops, analgesic and antihistamine, and can refer for ENT for follow up, or if the patient came in with non-resolving case, need to refer for ENT to review to exclude other malignant external otitis externa. So in ear infection of otitis media, it is the infection of the middle ear. So common in childhood illness are usually caused by Haemophilus influenza infection or Marazella catarrhalis. Signs and symptoms include fever, pain, discomfort, otorrhea, usually purulent when perforation occurs, and erythema or swelling of the tympanic membrane upon examination otoscope. So in infants, usually the infants will come in with irritability, tugging of affected ear, ada fever juga. So management, if the patient is having acute viral otitis media or suspecting acute viral otitis media, is usually self-limiting. Enough asymptomatic treatments such as analgesics and antipyretics. For bacterial otitis media, we can give oral antibiotics such as amoxicillin, augmentin, or erythromycin, antibiotic ear drops. It is likely indicated in ruptured tympanic membrane and refer ENT for follow-up. It needs early treatment with antibiotics to prevent further complications such as meningitis, labyrinthitis, brain abscess, or mastoiditis. So for nasal nose, this is nasal foreign body usually mainly encountered in children and adults with mental disabilities. Objects are commonly include toy parts, beads, paper, piece of food, and sometimes also button batteries. Late presentation, usually patient will come in with unilateral purulent nasal discharge or halitosis. The management is to attempt of removal with appropriate instrument and adequate anesthesia or sedation. Usually children dia akan agitated, tak kooperatif. So if fail initial attempt, akan buat other subsequent removal attempts is more difficult. So if we don't have enough tools or it is hard to remove, then it is better to refer ENT for removal. The next is nasal trauma, nasal bone fracture. Usually it is the history is patient came in with direct trauma to the nasal bone. This is the most common facial bone fracture as the nose is prominent in the face. So nasal bone fracture without obvious deformity or displacement usually does not require active management. If the epistaxis is present, we need to control the epistaxis. So on examination, we can palpate for bony crepitus by moving nasal bone. So we can also see there is an ecchymosis, deformity of the nose. So if displaced fracture, we need to refer ENT for reduction. Usually reduction will be done after the swelling subsides. So undisplaced, usually they put POP cast for use while sleeping to prevent displacement. Also need to rule out eye injury, orbital fracture or entrapment of eye muscle. So acute intervention, we need to look for primary survey if ABCD is compromised. So if there is epistaxis, need to manage the epistaxis first and look for septal hematoma. In the picture, there is this
Hamizah, I'm sorry to intervene.
Yeah.
Tell me, what are the ways of control the epistaxis at ED level?
Epistaxis in ED level. Sekejap kita kalau saya ni next slide. Okay. So ED level usually dekat rumah patient can do the first aid first lah. So lean forward, head flexion and continuous alar pressure 10 to 20 minutes. Alar pressure is just at the tip of nose, just below the bony parts. Then if the epistaxis does not resolve for the 10 to 20 minutes, we can put nasal packing. Nasal packing for the traditional method, we use gauze and bayonet forceps. So kalau usually yang newest method in ED, kalau tak salah dekat kita ada rapid rhino. So this is the
Ada ke tak ada?
Ada, doktor, saya pernah tengok masa Houseman.
So everyone, all my MOs, please aware we do have rapid rhino. It is kept by our penyelia. If needed, please ask for it.
So rapid rhino ni they can use for anterior or posterior nasal packing. It has balloon. We can inflate the balloon over the posterior side or anterior side to stop the bleeding and refer ENT for review. Usually the nasal packing can be put up to 24 to 72 hours lah.
Do you give any anxiety for epistaxis?
Yeah, usually we cover with antibiotics, Doctor.
Perlu ya?
I think ada yang saya baca kalau early antibiotics can be given.
It's depend, okay? It's argumentable punya topik jugalah. Tapi one, you have to look at the few things before you nak bagi antibiotic. Look at what type of epistaxis and how long you going to place the nasal pack inside the nostril. If it's anything beyond 48 to 72 hours, yes, you need to give the patient prophylaxis antibiotic. If they want to remove, if the bleeding stop and you remove it less than 24 hours, there's no role of antibiotic, nah? Okay.
Saya sentuh sikit lah pasal septal hematoma. Usually if patient came in with trauma, we need to look for septal hematoma lah, since it is really emergency case for ENT lah. Usually septal hematoma can cause erosion of the nasal septum lah. So dia can ENT will do the urgent IND or nasal packing lah to prevent reaccumulation. Okay. So epistaxis, tadi kita dah sentuh sikit lah pasal epistaxis. Usually usually epistaxis ni dia based on vascular supply lah. Kalau dekat anterior ischia plexus, dia branches of carotid artery. Dia consist of anterior ethmoidal artery, superior labial artery and greater palatine artery. So for the posterior part is distal branches of external carotid artery. It consists of posterior ethmoidal artery and spinopalatine artery. So usually dekat kisabah plexus is the most vascularized area. So this is where the epistaxis come from lah. So kalau if let's say kita try try pinching the nose and nasal packing anterior tak dapat nak settle down the epistaxis, then we need to exclude the posterior bleed lah. So usually posterior side bleeding side usually present with bilateral nose or blood draining down the oropharynx. Factors of epistaxis usually idiopathic factors. So local factors and systemic factors. So local factors usually idiopathic 80%, trauma, inflammatory or infectious, post-operative like recent nasal surgery or cancer or drugs. Systemic factors usually ada blood dyscrasia like von Willebrand syndrome, hemophilia, hypertension, drugs or organ failure. Ini tadi kita dah tu. Next is foreign body of aerodigestive tract. So in the throat, if the foreign body is visible, usually patient foreign body in aerodigestive tract to diagnose based on patient's history lah. So if the patient came in said ada ingested of foreign body, painful, and kita kena tanya balik lah dekat mana sakit sekarang. If the pain is in the throat, so try to look for the foreign body lah. If the foreign body is visible and can be removed using good examination, thumb depressor and forceps. So usually fishbone ni akan lodge in tonsils, vallecula, piriform fossa. Next is larynx or hypolarynx. We need to confirm foreign body by history. So X-ray, neck, epilateral soft tissue neck, and then the radio opaque foreign body can be seen. And then kita kena refer ENT for removal. So then next is esophagus. So ni pun sama, kena confirm foreign body punya placement by proper history lah. Usually we need to locate the foreign body first lah. So need to do X-ray, AP, lateral of neck, soft tissue neck, and then maybe patient will indicate for upper GI endoscopy to confirm, and or then rigid esophagoscopy for removal lah by ENT team. One of the case that I encounter in green zone, pain over the throat area, dia kata dekat over the neck lah, lower neck. Since patient ingested, dia kata foreign body is fish. So we can see the fish bone is at the esophageal area lah. Next is foreign body of aerodigestive tract.
Hamizah, I'm sorry, can I have the X-ray back?
Ya, Doktor.
Okay. Was it a successful removal?
Yes. The patient was done removal in GA then the next morning because patient came in at 11 at night.
Okay, good.
So next is a trachea or bronchus, foreign body in trachea or bronchus. We need to confirm foreign body by history of foreign body, inhalation, initial choking, coughing, cyanosis may be followed by asymptomatic period of few months before blood stain sputum comes. Examination, auscultation can reveal stridor or reduced air entry, rhonchi, light breath sound. So in X-ray, we can see any shadow within the trachea, bronchial air shadow can indicate a foreign body. Collapse consolidation also can be seen. So initial management consists of blows between shoulder blades of Heimlich maneuver. So and then upon confirmation, parenteral antibiotics and steroids should be administered to prevent infection and reduce inflammation. Then this patient also need to refer for higher center removal. Next is throat infection, peritonsillar abscess or quinsy. This is the pus collection in peritonsillar space, usually between tonsil capsule and superior constrictum, so group, and usually the organism involved with group A streptococcus. Patient will come in with hot potato voice, drooling, trismus, neck pain, or sometimes fever. And then on examination, we can see the deviated uvula. Uvula will deviate to contralaterally. So patient will come very painful, ada dysphagia, odinophagia and dehydration. Also drooling juga kadang sebab dia susah nak menelan. So acute management, sometimes because of trismus and very painful, sometimes incision and drain aspiration of the pus will relieve the symptoms. So this patient needs to be admitted for IV antibiotics.
Okay, Hamizah, can I add on?
Sorry, Doctor?
Dato' Ida nak add a little bit Okay, to everyone, as you all have encountered most of the ENT emergency according to your individual experience, where do you see the most case of ENT emergencies? At which zone?
Green.
Okay, green. Yang lain? Hamizah sampai dah berapa lama dah dengan kita,
Almost 5 months.
5 months, okay. The others, can seniors give me more comment or feedback? Siapa yang ada dalam tu? Dr. Kamini?
Green zone, Doctor.
Green. And how about the Chiang? Izari? Okay, so we cannot deny that most of the ENT emergency we encounter in green zone. So I really request all the MO, tak kira lah senior ke junior occur. We have a high index of suspicion when we encounter the ENT cases. It may sound very benign in presentation or by history, but there are few clinical features or examination which is a landmark which indicates that it's a emergency. Patient memang tahu benda tu is emergency, is our responsibility to elicit the sign and symptom. Contoh ya, kalau budak kecil, you are thinking it's epiglottitis. How do you think the patient will present? Hamizah, you want to give a try?
Budak kecil epiglottitis usually
About 3 years old or 3 years old, epiglottitis.
fever.
Yes. The typical history which you may get from the mom.
Dia noisy breathing.
Okay, very good.
Refuse to tolerate orally.
Good.
And then
Drooling of.
drooling of saliva.
Yes, because the child refused to swallow the saliva due to swelling over the epiglottic side. So drooling of saliva, difficulty in swallowing, reduced oral intake, a toxic looking. Okay, you should have a high index of suspicion. Okay, how about in older people? Boleh lah, dia orang boleh tolerate kan, apa benda susah nak telan pun dia pun tolerate juga. So what do you want to look at in old people?
Old people usually came with neck pain lah. Neck pain, dysphagia, difficulty to swallow. But
Okay.
sometimes drooling tak terlalu lah.
Tak begitu. So look at all the red flag sign in ENT. Example, difficulty in swallowing, difficulty to open the mouth, hoarseness of voice, as you mentioned earlier. Upper speech, hot potato,
Voice.
Okay, then put extra effort to examine the oral cavity. Go for bimanual palpation. Okay, and in older people, comorbid does carry a weightage. Patient yang ada DM, look at how good is the diabetes is being controlled. In old people, the history may dah berminggu-minggu dah dia punya swelling. Who knows, the abscess is already there for very long and is suddenly increasing in size, which compromise the airway. Okay, so in this group of patient, tak perlulah kita letak patient dalam green zone. Patient memang nampak comel di depan mata kita, but the airway is being very much compromised if you want to anticipate it later on. So you need to put the patient in high priority area, which is our red zone, and inform the seniors or inform the emergency physician to look for further evaluation. Okay, bukan senang nak handle ENT emergency ni, especially if it involves the throat and the neck area. Okay, so you can proceed further.
Okay. So this is peritonsillar abscess drainage. Usually first is need to numb the palate first and then anesthetize the area and extract pus as much as possible during the syringe. This is for relief symptoms only lah.
Yang ini Dr. Vila pun tak berani nak buat kat.
Usually kita refer.
Usually we don't encourage this procedure to be done in ED lah. Again, airway will be an issue in this group of patients. So do not anticipate for this procedure at ED level. Refer to our ENT colleague. First thing, I want you all to be good in identification in this group of patients, especially your Quinski sign. Patient yang ada chronic tonsillitis, look hard for Quinski sign. Okay, and yeah, the next one.
Next is Ludwig's angina. This is a life-threatening cellulitis of soft tissue involving floor of mouth and neck. It involves 3 compartments of the floor of the mouth, the sublingual, submental and submandibular. Infection is rapidly progressive. It can lead to potential airway obstruction. It is caused by raised floor of mouth and woody hard feel. Tongue will push back, causing the airway obstruction. Usually originates as a dental infection of the second or third mandibular molars, including partially erupted third molars, or in patient with a poor dental hygiene. Usually we can ask for the history. Patient had history of recent dental extraction or dental pain. Patient can come in with signs and symptoms of neck swelling, neck pain, swallowing, speaking difficulty, trismus, bold neck appearance, mouth pain, hoarseness of voice, drooling, tongue swelling, neck stiffness, and sore throat or stridor. So this need an urgent referral to ENT lah for admission, IV fluid, antibiotic.
Sorry.
But yeah, betul.
Not all the signs will present as a hole in a patient with a Ludwig angina. It may as simple as just a swelling at the floor of the neck with difficulty in opening of the mouth. Itu je complain patient. Tapi tak ada pun airway compromise, breathing no issue. But you know the location is very much typical, have a high index of suspicious. Okay, please do not discharge the patient at ED level. That patient require immediate care. Okay, if you have any doubt, please ask. Please ask us. Okay.
So usually patient will need release incision in neck and refer for definitive management if airway is threatened. So definitive management is usually first is airway protection. The patient will be this will be done with by our ENT team lah.
Bukan ED yang manage. Jadi it's not even our management when it comes to airway in Ludwig angina. It is not easy to intubate a patient with a Ludwig angina. It's a very, very complicated procedure. So we need the cooperation from the patient when we are protecting airway in this group of patients. That's why it is advisable to refer the NS and also ENT team by proceeding for further management by doing a fiber optic awake intubation.
So this is the image of when the tongue is pushed backward, causing the airway obstruction. The infection is in the submandibular space. The swelling can cause neck and pushing the neck towards for causing the airway obstruction. So after done with airway protection, then only we can give broad spectrum IV antibiotics for the patient.
Boleh kot. There's no harm you give the antibiotic earlier. No harm. It doesn't going to interfere with your management. It's okay. But yeah, usually they'll be very much sepsis when it comes to a Ludwig angina. So you need to treat the hypertension. Do not cause any more panic in the patient. Just make sure the patient is comfortable in whatever position patient wanted. Okay, and then you proceed with further management, refer to the respective team, and you do the necessary supportive management for the patient. Okay, what was the main aim for me to request you to present this topic is I want our EDMO to familiarize with the emergencies in ENT. Okay, please go through the slides and okay, starting from the nose, the mouth, and the nose. There are few emergencies which may appear benign. However, the treatment is very, very... The outcome of the patient is devastating if we do not intervene at the right time, at the right place, with the right equipment. You all need to aware that we do not have the appropriate tools in order to manage the ENT emergencies in our ED setting. I'm sure it's not available in most of the ED setting also. So we need to identify this target group of patient and refer to the primary team as early as possible to prevent all the necessary complication. Yeah, team. So yeah, good effort by two presenter. And any question by the floor? Sama juga kalau pitch epiglottitis, Dr. Vila encountered 2 cases by personal. Even though the patient has an airway compromise, I just do what is supportive for the patient, to refer to the pit stim as early as possible. And there is a role of NIV in this group of patients. So they proceed with NIV. We calm down the child and give antibiotic as early as possible, hydration, and go for NIV. But if it's life-threatening, you want to intubate, yes, we need to intubate with all the precaution taken necessary lah. Okay, any question by team? Okay, Hamizah, you're okay? Good? Okay. Thank you very much, everyone.
Thank you, Dr. Vila.
Okay, bye-bye.